Hello, and welcome to this Clinical Care Options Oncology podcast. I am your host, Ryan Topping. In today's episode, we are joined by Dr. Laura Spray from the Massachusetts General Hospital in Boston, Massachusetts, and Dr. Shipra Gandhi from Emory University in Atlanta, Georgia. Together, they will be discussing the key takeaways from a large educational program on available treatment options and emerging new data for patients with HER2-positive metastatic breast cancer. This episode is part of a larger educational program entitled Advancing Precision Care and Shared Decision-Making in First-Line HER2-Positive Metastatic Breast Cancer Management, Expert Insights, Patient Resources, and Adaptive Decision Support. For more information on Drs. Spring and Gandhi, along with a link to the complete program, including interactive patient cases, patient resources, an interactive decision tool, and an on-demand webcast from the live program on this topic, please visit the show notes for this episode. Now, let's hear what the experts have to say regarding treatment options and new horizons in first-line treatment for HER2-positive metastatic breast cancer.
The DESTINY-Breast09 study was one of the major presentations at ASCO 2025. This was a global randomized 3-arm phase 3 trial enrolling 1,157 patients with untreated HER2-positive, locally advanced, or metastatic breast cancer. There were 3 comparison arms. One was trastuzumab deruxtecan, TDXD, plus pertuzumab, and that enrolled 383 patients. And that was one of the arms that was presented at ASCO. Another arm, the data was not yet reported, is the TDXD plus placebo arm, which enrolled 387 patients. And then the comparison was standard THP, so a standard taxane plus trastuzumab plus pertuzumab, enrolling 387 patients. I think importantly, whenever we look at a study, it's important to think about the cohort characteristics. So in this trial, about 50% of patients had de novo metastatic disease, and about 54% were hormone receptor positive. And overall, nearly half of patients had received treatment in the early stage setting. The key efficacy outcome for DB09 was progression-free survival. And overall, the median progression-free survival was 40.7 months with TDXD plus pertuzumab versus 26.9 months with THP. This result was even more pronounced when you looked at the investigator-assessed PFS, 40.7 months versus 20.7 months, for a hazard ratio of 0.49. There are multiple other secondary endpoints as well. The 24-month PFS rates were 70% versus 52%, favoring TDXD plus pertuzumab. The objective response rate was 85.1% versus 78.6%, again favoring TDXD plus pertuzumab. In terms of complete response rate, 15.1% versus 8.5%, again favoring TDXD plus pertuzumab. Overall survival data are immature at this point, with the trend favoring TDXD plus pertuzumab. Another important aspect to consider is safety. In terms of grade 3 or greater treatment emergent AEs, it was pretty similar in the two groups. In terms of serious treatment emergent AEs, that was 27% versus 25.1%, again fairly similar between the two groups. Of course, a really important AE of interest is interstitial lung disease. So ILD occurred in about 12% of patients on TDXD plus pertuzumab. This was mostly grade 1 to 2. About 0.5% of cases were grade 5. And overall, this 12% is compared with just 1% in the THP arm. Other side effects like nausea, vomiting, and constipation were more common in the TDXD arm, but no new safety signals were identified. So overall, this was major study presented at ASCO and is creating a lot of buzz, of course, in the oncology community. TDXD plus pertuzumab significantly increased the median PFS compared to the long-standing THP regimen and represent the first major advancement in the first-line treatment of metastatic HER2-positive breast cancer in over a decade. So this does establish a potential new standard of care. There are a number of clinical questions, though, that comes up with this study. As many people know, TDXD compared to THP, there is a difference in tolerability. With the THP regimen, we do often drop the taxane after several cycles, and patients can then continue on HP for a long, long time and experience a very good quality of life. So that's, I think, been a major topic of discussion.
DESTINY-Breast09 presented remarkable results showing us that the first-line standard of care has likely now changed to T-DXd and pertuzumab. So we wanted to go over a clinical interactive decision tool for HER2-positive metastatic breast cancer. In this tool, 5 experts in breast medical oncology were questioned about their preference for first-line management of metastatic breast cancer. And unanimously, everyone agreed for the Cleopatra regimen, that is the taxane, trastuzumab, and pertuzumab, which would be the standard of care in the first-line HER2-positive metastatic breast cancer setting. Couple of experts also said that they would consider stopping the taxane after several cycles because of potential for cumulative toxicity and then just continuing patients on trastuzumab and taxane. At San Antonio last year, 2024, we also heard that data from the PATINA trial, which was a phase 3 randomized clinical trial that enrolled triple-positive metastatic breast cancer patients in the first-line setting who had received induction with the Cleopatra regimen that was taxane, trastuzumab, pertuzumab for 6 cycles, and those patients who had a complete response, partial response, or stable disease, they were then randomized to either continue the trastuzumab, pertuzumab with endocrine therapy, or the other arm was when palbociclib was added to this combination. So it was trastuzumab, pertuzumab, endocrine therapy with palbociclib. And in this study, we saw that there was a remarkable improvement in progression-free survival from 29.1 months to 44.3 months with a hazard ratio of 0.74, showing a 15-month improvement in progression-free survival. So based on this data presented from the PATINA trial, the experts were again questioned as to how their treatment recommendation would now change for metastatic triple-positive breast cancer patients. And unanimously, everyone agreed that they would still continue treating these patients with taxane, trastuzumab, and pertuzumab. But again, based on the PATINA trial, everyone favored dropping the taxane after 6 to 8 cycles or maximum response, and then considering continuing trastuzumab, pertuzumab with the addition of palbociclib and endocrine therapy as maintenance in patients who have achieved good response or stable disease after induction treatment. So then at ASCO this year, as Dr. Spring already presented the data from DESTINY-Breast09, all the 5 experts were again questioned as to how their treatment recommendation would now change for HER2-positive metastatic breast cancer patients. And I think the data from DESTINY-Breast09 was very encouraging, showing that T-DXd is not only effective in the second-line setting, which we already have seen data from DESTINY-Breast03, but now based on DESTINY-Breast09, T-DXd with pertuzumab had a remarkable improvement in progression-free survival compared to the Cleopatra regimen. So everyone agreed to treat patients with T-DXd and pertuzumab in the first-line setting in metastatic HER2-positive breast cancer. However, I think all the experts agreed that there has to be some kind of shared decision-making because it is clear that T-DXd is a very effective agent both in the second-line and in the first-line setting. But given the toxicities associated with T-DXd and the dose interruptions that were seen, dose interruptions and dose reductions that were seen on the clinical trial, the question is that would a first-line approach be more effective, or could this also be given in the second-line setting? I think the sequencing question could not be very well addressed by the design of DESTINY-Breast09 because in the control arm, that was THP, only 10% patients had gotten T-DXd in the second-line setting. So the PFS2, although the PFS2 was higher in T-DXd pertuzumab, given the small number of patients who actually had the crossover and got T-DXd in the second-line setting, I think the question could not be fully addressed. So this brings us to the question whether you would give T-DXd pertuzumab to all the patients or would there be a subset of patients? And I think all the experts agreed that they would give it, they would prefer it in the first-line setting. But there are some patient populations where we would definitely want to consider T-DXd pertuzumab, and those would be patients with brain metastasis or patients with significant amount of visceral disease or those who have had recent progression after neoadjuvant or adjuvant HER2 targeted therapy. So on the DB09, the disease-free interval had to be more than 6 months. So for this patient population, which is representing aggressive disease where the recurrence is happening even 6 to 12 months after completion of anti-HER2 therapy, I think we would prefer the T-DXd pertuzumab regimen. And for the triple positive metastatic breast cancer patients, I think the other question is the PATINA trial looked so impressive where addition of palbociclib to AI and trastuzumab pertuzumab prolonged progression-free survival. And on DB09, TDXD was continued until disease progression. So it's not clear as to what should be the duration of TDXD. Do you really need it until disease progression, or should we wait until maximum disease response and then potentially switch TDXD to trastuzumab? So a lot of experts thought that it might, we may also continue TDXD until maximum disease response. And then for our triple positive metastatic breast cancer patients, we could have a maintenance strategy where we are doing trastuzumab, pertuzumab with the addition of palbociclib and AI. Some of the experts also thought that there could be shared decision making. For example, if a patient has very slow growing disease, de novo disease, and has low volume of disease, a lot of comorbidities where we don't think we would want to treat these patients with TDXD pertuzumab, we could potentially also consider the Cleopatra, taxane, trastuzumab, and pertuzumab regimen for those patients. So, Laura, now I would just turn it to you and would like to see what your thoughts are as to who are the patients you think the DB09 regimen would be applied in the first line setting, and what are your thoughts on the duration of treatment with TDXD?
These are great questions, and I agree with all your comments. I think it's tough because the patient population included patients who were treated in their early breast cancer setting. As you said, some recurred early, and that's definitely the group we're more concerned about. It also included patients with de novo disease, and clearly they benefited from TDXD plus pertuzumab as well, but that's also a patient population that we know has done so well with THP and then shifting to maintenance HP. I think we all can recall or have patients who have been on maintenance HP for years. And that when I think about indefinite TDXD, it's hard to think about that. It's a drug that over time, not for all, but for many patients, can get harder over time. The fatigue impact is significant. Of course, nausea is common as well. So I am very interested in the idea of induction. And I know that's being explored in some current studies and discussion about different study designs, I'm sure, as well. And how do you define that, I think, is one challenge. Or do you take the approach where it's a set number of cycles like we do with the taxane? So sometimes people think about 6 to 8 cycles. But I do think to individualize it would be most helpful. But I think we need some trial guidance in how to best do that. And as you said as well, the PATINA data, how do we think about that in context of DB09 when those results were so impressive as well? And we now, for patients who also have hormone receptor positive disease, have this additional tool that we could use.
Yeah, I totally agree about your comment on the duration of treatment. I think it is unclear if we should do 6 to 8 cycles, or should we do it until maximum disease response? And clearly there are clinical trials that are being designed to answer this very question. I think the discussant at ASCO had also mentioned that who are the patients where we really think the DB09 regimen would be preferred, and specifically for patients with brain metastasis, recent disease progression, significant visceral disease, as well as those with the PIK3CA mutation. Because when we see the results from the taxane, trastuzumab, pertuzumab, it's really these patients with PIK3CA mutation who are not doing very well on that regimen. And when we saw the results from DB09, both PIK3CA mutation, I think there were 30% patients on DB09 with PIK3CA mutation, they had superior outcomes compared to the THP regimen. So I think if we are trying to tease out particular subsets of patients who would benefit from TDXD pertuzumab, I think we have to consider the clinical factors as well as certain biomarkers where we really think this regimen would be superior compared to THP.
I agree. And I think that was a really interesting discussion point about the PIK3CA mutations. I think often we're not as focused on genomic testing for first-line HER2 positive MBC, and this could change that.
I think it's so interesting that over the last 6 months, the treatment for first-line metastatic HER2-positive breast cancer significantly evolved from the taxane HP regimen. Then we see this data with the hormone receptor-positive HER2-positive patina regimen, and now with DB09. And now we are actually trying to think how to incorporate the patina into the DB09 design, especially for our triple-positive metastatic breast cancer patients.
I think it's going to be really interesting to look at real world data over time to see how folks do apply this. I imagine a few different approaches will happen where TDXD is either, as we said, used until you reach kind of maximal response or like a plateau in response. Some may use it, as we said, for 6 to 8 cycles. And I wonder, probably more commonly, others may use it until through shared decision making and tolerability that it's decided to stop and transition, say, to HP. And for those with HR positive disease, I think that's where the patina regimen will come into play as well.
A survey for persistent educational needs was conducted to understand first-line treatment after adjuvant anti-HER2 therapy. Learners showed marked improvement in evaluating latest data, that there was a 25% increase and ability to tailor interventions for addressing safety profile challenges with antibody drug conjugate therapy. There was a 17% increase following CME education. Most of the learners also indicated the decision topics helped increase their awareness about these topics and that they will be sharing or integrating this new information together with their colleagues.
One of the situations was considering a patient with progression 6 months or less on either neoadjuvant or adjuvant pertuzumab containing regimen, and whether or not that patient would be a candidate for frontline TDXD. Prior, on the pre-tests, 62% felt they would be a candidate, and then the post-test, there was an increase in understanding of the recommendations, and 84% felt that patient would be a candidate for TDXD. Of course, with the DB09 data, this is all evolving, and there'll be greater use of TDXD in the early line settings.
Thank you, Dr. Spring and Dr. Gandhi, and thanks to you, the listener, for joining us. As a reminder, to view the full program, Advancing Precision Care and Shared Decision-Making in First-Line HER2-Positive Metastatic Breast Cancer Management, expert insights, patient resources, and adaptive decision support, and to access online content associated with this discussion, please click the link in the show notes. As always, thanks for listening.